a neurodegenerative process unfolds, relentlessly targeting motor neurons. Amyotrophic lateral sclerosis emerges as the most common progressive motor neuron disease. It involves simultaneous degeneration of upper motor neurons in the cortex and lower motor neurons in the brainstem and spinal anterior horn cells. Global incidence ranges from 1 to 3 per 100, 0, with prevalence around 3 to 5 per 100, 0. Mean onset is around 60 years. The disease was first described by James Parkinson in 1817 through clinical observation of progressive motor decline. Pathologically, there is degeneration of corticospinal tracts and anterior horn cells with gliosis and microglial activation. A hallmark finding is ubiquitin and TDP-43 positive intracellular inclusions within affected neurons. Despite widespread motor system failure, sensory pathways, cerebellum, and ocular movements are typically preserved until late disease. Lower motor neuron signs include asymmetric weakness, muscle wasting, fasciculations, and cramps. Upper motor neuron signs include spasticity, hyperreflexia, and increased muscle tone. Bulbar involvement causes dysarthria, dysphagia, and progressive tongue weakness. Disease progression is relentless, with average survival of 3 to 5 years and death usually due to respiratory failure. Diagnosis is clinical, requiring combined upper and lower motor neuron signs across multiple body regions. World Federation of Neurology criteria define definite ALS as UMN and LMN signs in 3 regions. Neurofilament light chain levels are elevated and correlate with disease severity and progression. Genetic forms account for about 10% of cases, most commonly involving C9orf72, SOD1, TARD, and FUS. C9orf72 expansions produce toxic RNA foci and dipeptide repeat proteins leading to neuronal injury. Pathogenesis involves excidotoxicity, oxidative stress, mitochondrial dysfunction, and impaired protein clearance. Microglia and astrocytes amplify neuroinflammation, accelerating motor neuron degeneration. Key differentials include cervical spondylosis, multifocal motor neuropathy, vitamin B12 deficiency, and lead toxicity. A crucial clinical clue is preservation of eye movements and bladder function until late stages. Treatment is centered on riluzole 100 mg per day, which provides a modest survival benefit of about 3 months. Edaravone acts as an antioxidant therapy and slows functional decline in selected patients. Gene-targeted therapy, such as tofersen, reduces SOD1 protein expression in familial ALS. Respiratory failure is managed with non-invasive ventilation using BiPAP to prolong survival and improve quality of life. Nutritional support often requires gastrostomy feeding to maintain caloric intake in advanced disease. Communication aids such as speech synthesizers help maintain interaction as bulbar function declines. Mobility aids, including splints and assistive devices, improve function and reduce disability in progressive weakness. The overall prognosis remains poor, with most patients succumbing within 5 years of symptom onset. The key clinical message is that ALS is a relentlessly progressive motor neuron disease with no cure, requiring early recognition and multidisciplinary supportive care.